Hello students, today we will discuss the anatomy of oculomotor nerve. Now this is the third cranial nerve. Now in today's lecture we will discuss the whole oculomotor nerve along with its important clinical anatomy. So when you will see the oculomotor nerve, it is entirely motor in function. So when you will have the oculomotor nerve, you will realize that it is having only the efferent output. There is no sensory or afferent inputs in this nerve. So this nerve mainly supply the muscles which are known as extraocular muscles. Now there are two muscles, one is superior oblique which is supplied by the fourth cranial nerve SO4 and the lateral rectus which is supplied by the sixth cranial nerve. Remaining all the extraocular muscles supplied by the third cranial nerve. Now apart from the extraocular muscle, this third cranial nerve supply the levator palpebrae superioris, which is a very important muscle present in the upper eyelid, and it also supply the smooth muscles. Now the smooth muscles, there are three smooth muscles supplied by the oculomotor nerve. One smooth muscle is detached part of the levator palpebrae superioris, which is present in the upper eyelid and known as Mueller's muscle. And apart from that, there are two small smooth muscles present inside the eyeball. These are known as sphincter pupillae and ciliary muscle. So whenever you are having the oculomotor nerve, you have to keep in mind that it is purely supply the muscles which are of both variety, skeletal as well as smooth. Clear? Now, what are the nuclei responsible for these motor output? So there are two motor nuclei which are present or related with this oculomotor nerve. First is known as main motor nucleus, second is known as accessory parasympathetic nucleus, or it is also known as Edinger Westphal nucleus. Now this is again the question for your exam, that Edinger Westphal nucleus is a nuclei of which cranial nerve? Answer is third cranial nerve. Now these nuclei located in the midbrain, but when you will see the midbrain is having the two colliculi on the posterior aspect, superior and inferior colliculi, and these both nuclei of oculomotor nerve present at the level of superior colliculus of midbrain. This is again the question for your exam. Then the another important thing is that both the side of the oculomotor nerve nuclei fuse partially and they will form a nuclear complex. Now in this diagram you can see that this is your section of midbrain at the level of superior colliculi. The superior colliculi is a elevation on the posterior surface of the midbrain. Now at this level you can see that this is the central gray matter. Now in this central gray matter you can see that there is a presence of the both nuclei, motor as well as Edinger Westphal nucleus. Now here you can see that this is the motor nuclei and both the side of motor nuclei join together in a triangular form, and this nuclei which will join together is known as Purlia's oculomotor nuclear complex. Sometimes you have this question in your exam, what is Purlia's oculomotor nuclear complex? So what will happen that the motor nuclei of both the side partially fuse together and they are known as nuclear complex of Purlia's. Then the important thing about this complex is that it lies on the ventral aspect of your periaqueductal gray matter. Now if you will see this section, you can see that this is your aqueduct. Now this will become the dorsal aspect and this will become the ventral aspect. So you will realize that this nuclear complex is present on the anterior side of this aqueduct, and that's why it is written it is ventrally placed, not dorsally placed. So there are two questions from these two lines. First is, what is the location of oculomotor nerve nuclear complex? It is inside the central gray matter or outside the central gray matter? Answer is inside the central gray matter. The second question is that this nuclear complex is ventral to the periaqueductal area or dorsal. Answer is ventral. Then in this same area you are going to see the Edinger-Westphal nucleus also, but the Edinger-Westphal nucleus lies just behind these motor nuclei. So here this is the Edinger-Westphal nucleus. Clear? So whenever you are reading the nuclei of your oculomotor nerve, you have to keep in mind that Edinger-Westphal nucleus as well as the main motor nucleus both are present at the level of superior colliculus in the midbrain, and they are present inside the central gray matter. Now, what are the functional components of this third cranial nerve? Now, as I already told you that it is a pure motor in nature, so it is going to supply the muscles, and the muscles are of both variety. There are skeletal as well as there are smooth muscles which are supplied by this cranial nerve. Now you know that the smooth muscles, if supplied by any cranial nerve, become the general visceral efferent component. Efferent, why? Because these are motor. And the skeletal muscles, if they are arises from the branchial arches, then it will become spatial branchiomotor component. But you know that extraocular muscles does not take origin from the any pharyngeal arch. They arises from the somites, and that's why this function become general somatic efferent. Clear? So there is a confusion that so many students think that it is also spatial visceral, but I have to clear this thing here that it is not spatial efferent because the extraocular muscles is not having any origin from pharyngeal arches. So all the extraocular muscles arises from the somites, that's why it is general somatic efferent. Clear? Now, when you will see these two sets of your functional components, you have to keep this thing in mind that general somatic efferent, the nuclei is main motor nucleus. That is the main motor nucleus of oculomotor nerve, which supply the extraocular plus levator palpebrae superioris, and they all derived from somite. While the general visceral efferent, that is going to supply your smooth muscle, is a part of autonomic nervous system, and here there is a origin of preganglionic parasympathetic fibers. This preganglionic parasympathetic fiber is coming from Edinger-Westphal nucleus, which is also known as accessory oculomotor nuclei, and this is going to supply smooth muscles, that is your sphincter pupillae and ciliary muscle via ciliary ganglia. Now, general visceral efferent involved in the pupillary constriction and accommodation of the lens. There is one more functional component, and that is known as general somatic afferent. Now, some book says that these general somatic afferent carries the proprioception from extraocular muscles. Now, these extraocular muscles which are having the proprioception sense their afferents of proprioception with the help of ophthalmic branch of trigeminal nerve. But some book says that oculomotor nerve fiber may carry these general somatic afferents from extraocular muscle. But if you are seeing the major functional component, they are purely their efferent component. This component is not considered as a component of oculomotor nerve. This sense of extraocular muscles are generally carried by ophthalmic division of trigeminal nerve. Now, in this diagram, you can see that this is your oculomotor nerve, and you can see there are two important efferent output. Now, one output is coming from these motor nuclei, and these fibers are going to relay in extraocular muscles, while this is the Edinger Westphal nucleus, and these preganglionic parasympathetic fibers will go and relay in the ciliary ganglia. Now, from the ciliary ganglia, you are having the origin of postganglionic fiber. Those will enter in the eyeball and supply the constrictor pupillae and your ciliaris muscle. While this is the general somatic afferent. Now, this general somatic afferent carries the proprioception from these extraocular muscle, and it is going to relay in mesencephalic nucleus of trigeminal nerve. So, this is again the controversial that some author says that this trigeminal nerve nuclei, which is known as mesencephalic nucleus, receives the proprioception via the ophthalmic division rather than oculomotor nerve. Now, what is the course of this nerve? Now, when you will see the course, this third nerve passes ventrally through the red nucleus to emerge from brainstem. So, the first question is that when you will see this section, you can see that this area is known as red nucleus. Now, the nerve is going to emerge from the ventral surface. Now, this is the ventral surface of the midbrain, this is the dorsal surface of the midbrain. So, the nerve will come out from the anterior side or the ventral surface. Now, here you can see that the nerve fibers are passing through this red nucleus area. So, this is the first question for your exam, that which nerve fibers passes through the red nucleus? Answer is fibers of oculomotor nerve. The nerve emerges from the anterior surface of the midbrain. This is the second question, that which cranial nerves come out from the midbrain? Answer is third and fourth cranial nerve, but third is in the upper part, fourth in the lower part. But the fourth cranial nerve does not come out from the ventral surface. The fourth cranial nerve comes out from the dorsal surface. That's why here this anterior word becomes important for your exam. Sometimes you have the question that which cranial nerve emerges from anterior surface of midbrain. The only answer is oculomotor, because trochlear emerges from posterior surface of midbrain, not anterior surface. This oculomotor nerve lies on the medial surface of the base of cerebral peduncle above the pons. Now, here you can see that the cerebral peduncles are also known as crus cerebri. So, these are the two crus cerebri, and they are also known as cerebral peduncles. Now, the oculomotor nerve comes on the medial side of these peduncles in both sides. Clear? And this space between the two cerebral peduncle is known as interpeduncular fossa. So, the nerve lies on the medial side of the cerebral peduncles. At the nerve exit the midbrain, it immediately passes forward and laterally between the two very important branches of basilar artery. Now, what these branches? One is known as posterior cerebral artery and second is known as superior cerebellar artery. So, here you have to understand that there are two arteries, those will come in close relation to the oculomotor nerve near its exit, and these are posterior cerebral artery and second superior cerebellar artery. These both are the branches of basilar artery. This close proximity is very important for your clinical point of view, because if these arteries will get dilate, that is known as aneurysm, or any kind of vascular lesion will occur, this will lead to the compression of oculomotor nerve. Now, in this diagram, you have to first understand the exit of oculomotor nerve. Now, here from above downward, this is your crus cerebri of the midbrain. Now, here this is your pons, and below the pons this area is your medulla oblongata. Now, between the two crus, this area is known as interpeduncular area, which is an area between the cerebral peduncle. Now, here if you will see the exit of the nerve, you can appreciate that this is your oculomotor nerve. So what you have to keep this thing in mind, that oculomotor nerve comes from the medial side or medial margin of this cerebral peduncle, and once it will come out, it enters into this gap between the two peduncle, that is known as interpeduncular fossa. Now in this interpeduncular fossa, you have the relation of two important branches of basilar artery. Now this is the image of your base of the brain. Here you can see the formation of the circle of Willis. Now this is your basilar artery. Now here you can see this is the basilar artery which is present on the anterior surface of the pons. Now this basilar artery is dividing in the posterior cerebral artery. So this is the posterior cerebral artery and these are the superior cerebellar artery. Clear? Now if you will keep this area on here, what you will realize, these are the exit of your oculomotor nerve. So if you will compare this, you will realize that here is the basilar artery, then here you have the superior cerebellar artery, and you have the terminal branches, that is posterior cerebellar artery of basilar branch. So in this, if you will if you will keep this picture in your mind, and if you will have the position of your oculomotor nerve, you will realize that oculomotor nerves are in very close proximity with your posterior cerebral artery and superior cerebellar artery. That is why what will happen, whenever these arteries will get enlarged, that is known as aneurysm, or if the hemorrhage will occur, these nerves will get damaged or compressed. Now what will happen after that? So now what will happen, the nerve enters into the interpeduncular cistern. Now what is cistern? It is dilated subarachnoid space which is present in this interpeduncular fossa or in the interpeduncular space. Now in this interpeduncular space you are having one more artery, and that is known as posterior communicating artery of circle of Willis. So again, this posterior communicating artery aneurysm may lead to the compression of oculomotor nerve because of close proximity in the interpeduncular cistern. Now this nerve will go ahead. Now once it will go ahead, it has to puncture the dura mater. So it pierces the dura and it enters in the roof of the cavernous sinus between the free and attached margin of tentorium cerebelli. Clear? Now here you have to understand that this is the area of interpeduncular fossa, and in this interpeduncular fossa you are having the exit of your oculomotor nerves, and the immediate relation of oculomotor nerve is the branches of your basilar artery, that is posterior cerebral and superior cerebellar artery. And then it enters into the interpeduncular cistern where it is immediately related with the posterior communicating artery. Now further, once it will move, it is going to pierce the dura. Now this is the nerve which is piercing the dura, and then it will enter into this area which is known as cavernous sinus. Clear? So the nerve is coming from this ventral surface of the midbrain and it is approaching till here, and in this pathway this nerve is related with three arteries, one at the exit point, that is your branches of basilar artery, and second in this area where it is passing through the cistern of interpeduncular fossa. Now what is the relation in the cavernous sinus? So you know that oculomotor nerve continue in the anterior direction, and in the cavernous sinus it is related in the lateral wall. So this is the cavernous sinus, this is the lateral wall, and here you can see this is the oculomotor nerve, and you know the relation, that is the third nerve, then fourth nerve, then first division of fifth nerve and second division of fifth nerve. So, this is the oculomotor nerve, which is the uppermost relation in the lateral wall of the cavernous sinus. At the anterior pole of the cavernous sinus, this nerve ultimately is split. So, you have to understand that the oculomotor nerve finally divide into the two division, superior and inferior division, and these division will take place in the anterior end of your cavernous sinus. Now, these divisions will leave the cranial cavity and they will enter into the orbit. Now, to enter in the orbit, these division passes through the superior orbital fissure. Now, when you see the superior orbital fissure, there is a ring of Zinn or there is a tendinous ring is present. So, these two division passes through the tendinous ring. Clear? So, here the question is that oculomotor nerve leaves the cranial cavity. Answer is no. Oculomotor nerve will not leave, its division is going to leave the cranial cavity, and these divisions enter into the orbit through the tendinous ring of superior orbital fissure. Now, in this diagram you can see that this is the ring, and this ring area is here, which is enclosed by the ring. Now, this area of superior orbital fissure, which is enclosed inside the ring, is having the two divisions of your oculomotor nerve. This is the superior division of oculomotor nerve and this is the inferior division of oculomotor nerve. Now, in between the superior and inferior division, you are having a important nerve, and that is your nasociliary nerve. So, this is the nasociliary nerve. Apart from that, there is a one more structure in this area, and this is the lowermost structure is the abducent nerve or sixth cranial nerve. Clear? So, whenever you are having the question which nerves are passing or present in this area of superior orbital fissure, which is enclosed by the ring. So, there are four structures. One is the upper and lower division of oculomotor nerve, second abducens nerve, and third is nasociliary nerve. And the next question is that the oculomotor nerve enters the tendinous ring in two divisions. It enters with the help of two divisions, superior and inferior division, but the important thing is that which nerve lies in between these two divisions. Answer is nasociliary nerve. So, here you can see nasociliary nerve is a sandwich between the superior and inferior division of oculomotor nerve. Now, here you can see that this area is the entry of the structures in the orbit. So, this is the apex of the orbit, and this is known as cone of your muscles. So, these are the muscles which are extending from this part, and this is known as cone of the muscle. So, this is the apex of the cone from where the structures are going to enter. So, whatever the structures are entering through the tendinous ring, they will enter into this cone. They will enter into the cone of the muscle. Why? Because they are passing through the ring. If they are outside the ring, then they will not enter into this cone of the muscle. Now, what will happen with the superior division? The superior division is smaller and it passes upward over the lateral side of optic nerve. Now, this is the superior division, and this superior division will supply the two muscles only. That is why it is smaller. Now, what are these muscles? Levator palpebrae superioris and superior rectus. So, only the two muscles supplied by the superior division, superior rectus and levator palpebrae superioris. But here the question comes in your exam. The levator palpebrae superioris is having a small smooth muscle component, and that is known as Mueller's muscle, and that Mueller's muscle is supplied by the sympathetic nerve, and that sympathetic nerve is also present in this superior division. Now, from where the sympathetic supply comes? The answer is here, that while in the lateral wall of the cavernous sinus, the oculomotor nerve pick up the postganglionic sympathetic fibers. So, what is the entry point of sympathetic fibers in the oculomotor nerve? Answer is cavernous sinus. In the cavernous sinus, there is an internal carotid artery, and outside the internal carotid, there is a plexus of sympathetic branches which are coming from the superior cervical ganglia. Now, these branches of sympathetic plexus will enter into the oculomotor nerve, and ultimately they will reach to the Mueller's muscle. Clear? So, this question comes in exam, that how the smooth part of levator palpebrae, that is a detached segment, supplied by sympathetic nerve. So, answer is the sympathetic source comes from the cavernous sinus, where you have the internal carotid plexus, and this plexus is going to approach the muscle with the help of superior division of oculomotor nerve. Now, the important another thing is these sympathetic fibers runs in the superior division. Now, the question is that parasympathetic fibers, you know that we are talking about Edinger Westphal nucleus, and I told you that this Edinger Westphal nucleus is going to supply the constrictor or sphincter pupillae and ciliaris, but the important thing is that these parasympathetic fibers never the part of superior division. Superior division is having the sympathetic fibers along with the motor fibers. Clear? So, these sympathetic fibers runs in the superior division, and they will supply the smooth muscle of your levator palpebrae. Injury of this cervical part of sympathetic chain or the sympathetic fibers will lead to the partial ptosis because of the paralysis of Mueller's muscle. Now, what about inferior division? Inferior division is larger division, and inferior division is going to divide into the 3 further division, because it will supply the 3 muscles. So, here you can see that this is the inferior division, and this inferior division is dividing into the 3 division. One is going to supply the medial rectus, another will supply the inferior rectus, and the largest division is nerve to inferior oblique. Now, this nerve to inferior oblique is also having the parasympathetic fibers of oculomotor nerve, because here you can see that this nerve to inferior oblique is having connection with the parasympathetic ganglia, which is known as ciliary ganglia. Clear? So, that is why I told you that whatever the parasympathetic fibers of oculomotor nerves coming from Edinger Westphal nucleus, they will approach this ciliary ganglia through this inferior division. They will not enter into the superior division. So, superior division is not having any parasympathetic fibers. It is having sympathetic fibers for Mueller's muscle. So there are 3 divisions. The parasympathetic fibers in the oculomotor nerve, they passes into the inferior division, and more specifically branch to inferior oblique, which you can appreciate, branch to inferior oblique. Now, these fibers terminate into the ciliary ganglia, and these fibers act as a parasympathetic root of ciliary ganglia. The postganglionic fibers which arises from the ciliary ganglia are known as short ciliary nerve, and these short ciliary nerves which are having the postganglionic parasympathetic ultimately enters into the eyeball, and they will responsible for pupil constriction and accommodation. Now, so what are the functions of oculomotor nerve? In nutshell, there are 4 important functions. First, it is responsible for lifting of the upper eyelid. Why? Because it is supplying the levator palpebrae superioris and its smooth component. Second, it is responsible for the turning of eye upward, downward and medially, because it is supplying the extraocular muscles. It is responsible for the constriction of pupil, because it is parasympathetic to the sphincter pupillae, and it is responsible for accommodating the eye, because it is supplying the ciliaris muscle. Clear? So, now how this constriction of pupil has to check, or it is possible? So, the sphincter pupillae is a circular band of smooth muscle which is present in the iris at the margin of the pupil. Now this sphincter pupillae is an involuntary muscle which is supplied by the Edinger Westphal nucleus, which is a source of preganglionic parasympathetic fiber. And to check the action of sphincter pupillae, we are having the direct and consensual or indirect light reflexes. Clear? So what is the direct and indirect or consensual light reflex? When a light is shown into the one eye, the pupil of that eye constrict. This is the direct reflex. What does it mean? If I am showing the light to the right eye, the right pupil is constricted. That is direct. But in the consensual or indirect light reflex, I am showing the light on the right eye, but my left eye pupil is showing the meiosis or the constriction, then it is indirect. So the pupil of other eye also constrict is indirect. Clear? Now, what is the neural pathway of these light reflex? So first you should know the afferent. Now when you will see the afferent is traveled by the visual pathway, that is optic nerve, optic chiasma and optic tract. Now from the optic tract, some of the fibers leave the optic tract and they will synapse with a pretactal nucleus. Now pretactal nucleus is again present in the midbrain at the level of superior colliculi. So in this diagram you can see the neuronal pathway, that this is the eye. When you will show the light here, the pathway is carried by, the sense of the light is carried by the optic nerve, then optic tract, and from the optic tract here you can see that some of the fibers will leave the optic tract and they will enter here inside the midbrain. Now these fibers, those are leaving the optic tract and enter into the midbrain, will approach the nuclei which is known as pretactal nucleus. Now this pretactal nucleus, the impulses passes by the axons of the pretactal nucleus to the Edinger Westphal nucleus of both sides. Now this is the important to understand, that this pretactal nucleus of, suppose this is the right side, so this right side nucleus is going to excite or it going to synapse with the both side Edinger Westphal. This is the midline. So this is having the Edinger Westphal here, and this pretactal is having connection with both the side of your Edinger Westphal. So what will happen, that both side of Edinger Westphal nucleus will get stimulated. So the parasympathetic outflow from the oculomotor nerve will reach to the ciliary ganglia of both the side of your orbits. Clear? So what will happen, that if you are having the light here, this is the your pathway, so this constriction will take place. But because there is a stimulation of opposite side Edinger Westphal, so that's why this side of constriction will also take place. So this is the indirect and this is the direct light reflex. So what is the efferent? Efferent, I told you that parasympathetic fibers from Edinger Westphal nucleus travel through the oculomotor nerve, they will reach to the ciliary ganglia, and finally the postganglionic fibers will enter with the help of short ciliary nerve of eyeball and constriction will take place. So both pupil constrict in the consensual or indirect light reflex. The only answer is because the both side Edinger Westphal nucleus are stimulated because of the connection of pretactal nucleus. Now what is accommodation of eye? Accommodation of eye means to switch the visual attention consciously from a far away object to one nearby object. What does it mean? Suppose I am asking you to see at far point and suddenly I bring my finger in front of your nose and ask to see on the tip of my finger. So if you are looking at far and suddenly I bring my finger and you will start to look at the tip, then at that time whatever the changes are taking place in both the eyeball, they are combinedly known as accommodation of eye. So there are three important muscles which are having the role in accommodation. One is ciliary muscle. second in sphincter pupillae, and third medial rectus. How? Let's discuss. So, the ciliary muscle consists of smooth muscle fiber. Now, where you will find the ciliary muscle? Ciliary muscle present in the ciliary body. Now, in this diagram, you can see that this is the ciliary body. Now, in this ciliary body, you can see the muscle fibers. These muscle fibers are the ciliary muscle fibers. Now, its function is to focus the lens for near vision. So, when you are putting or bring your finger suddenly in front of your both eye, there is a focusing of the lens for the near object, and it is possible because of these three important steps. Now, what will happen? First, there is a contraction of ciliary muscle. Now, this contraction of ciliary muscle decreases the size of the ring formed by the ciliary body. What does it mean? Now, suppose this is the ring which is formed by the ciliary body, and this ring is having the ligaments or the zonal fibers which are connected with the lens. Now, here what will happen, that this is the outer ring. Now, this ring size, once it will decrease, when the size of the ring will decrease, these fibers will become loose or relax. Why? Because the size of the ring is decreasing by the contraction of ciliary muscle. So, when the ciliary muscle is contracting, the size of the ring is decreasing, and inside the ring you will have the connection of your fibers with the lens, and these fibers are known as ligaments. So, what will happen? The tension in the ligaments will reduce. It will reduce the tension in the suspensory ligament of lens. So, as the ligaments are going to relax, the lens become more round or more relaxed. Why? Because the lens is having its own elasticity. Clear? So, the tension is decreased on the suspensory ligament. Further, the tension of the lens is decreased. The lens become more round, and the rounding occurs because the lens is having elasticity. And what is the result? The result is that finally the lens is ready for the near vision, and it focuses the object on the retina. The muscle is supplied by the Edinger Westphal nucleus. So, whenever the parasympathetic stimulation occurs, this ciliary muscle will contract. So, this is the important thing to keep in mind, that how ciliary muscle is responsible for accommodation of your lens. Now, in this diagram, you can see that these are the ligaments, and these ligaments are holding the lens. So, you need to relax these ligaments, and these ligaments will relax once this ring which is present here, which is having the ciliary muscle in the outside, when the ring will decrease in the size, the ligaments become relaxed, and once the ligaments become relaxed, this lens become more round anteriorly. Clear? The convexity will increase. Now, this reflex has three components. First component is known as convergence. Convergence means there is a adduction of both the eyeball, and this adduction is responsible or caused by the action of both medial rectus. Now, what is the advantage of convergence? That the image is focused on the fovea of both the retina. Now, what is fovea? Now, this is the fovea centralis, and we have to focus the image here in this point of the retina, and it is possible when both the medial rectus act and convergence will take place. Then the second part is accommodation, which is caused by the ciliary muscle, and this ciliary muscle increases the refractive power of the lens. And the third is pupillary constriction, and this pupillary constriction is important of accommodation reflex because it control or restrict the entry of the light inside the eye, and by the help of this constriction, the margins or outlines of the image will enhance. Clear? So, these are the three important components of accommodation reflex. So, what is the afferent of the accommodation reflex? So, once you have the any accommodation stimulation, the sense is carried by the visual pathway, but it will ultimately reaches to the visual cortex. From the visual cortex, these afferent will approach this area of the midbrain, which is having the nuclei of oculomotor nerve. So, the impulses travel through the optic nerve, optic chiasma, optic tract and lateral geniculate body, optic radiation. Ultimately, they will reach to the visual cortex. Further, the afferent fibers from the visual cortex will approach to the oculomotor nuclear complex. So, you have to stimulate the oculomotor nuclear complex at the end, so that you are able to contract the ciliary muscle and sphincter pupillae. So, what will happen? There are two ways to reach the oculomotor nuclear complex. The first is that the visual cortex, from the visual cortex of there is a connection to the frontal eye field of cerebrum. Now, when you will see the cerebrum, now this is the cerebrum. Now, here you have the frontal eye field in the frontal lobe, and this is the visual cortex on the posterior side. Now, there is a connection between the two areas, and this connection is here. So, what will happen? That visual cortex is projecting to the frontal eye field. Now, from the frontal eye field, you are having the corticonuclear fiber. Now, these corticonuclear fibers is going to approach your midbrain. So, suppose this is your section of the midbrain. So, these fibers will approach the nuclei which are present into the midbrain. So, this is the first way how the afferents ultimately approach your oculomotor nuclei. The second way is that from the visual cortex, fibers will directly enter, and these fibers are known as corticotactile fibers. That is a connection between the visual cortex and tactile nuclei, pretactile nucleus, which is present in the midbrain. Clear? Now, what about the efferents? Now, when you will see the efferents arises from the oculomotor nuclear complex, and you know that ultimately what is happening, that from the oculomotor nuclear complex you have three types of the output. One is for the contraction of medial rectus, second is the parasympathetic output for sphincter pupillae and ciliary muscle. So, what will happen? That there is a contraction of medial rectus and the stimulation of Edinger Westphal nucleus, and ultimately what will happen? There is a stimulation of ciliary muscle and constriction of pupillary muscle will take place. Now, this is what you can appreciate in this diagram. Now, here this dark red line is showing the afferent and this dotted line is showing the efferent. So, till this midbrain, now this is the midbrain area where you are having the oculomotor nerve nuclei. So, whatever the fibers are approaching till this nuclear complex, they are known as afferent, and the efferent arises from this oculomotor nerve nucleus. So, the afferents are starting from the retina, they are passing through the optic nerve and they will reach to the visual cortex. From the visual cortex, you are having corticotactile fibers. These corticotactile fibers will reach to the pretactile area in the superior colliculus level, and from this oculomotor nerve nuclei, you are having the efferent for both somatic as well as visceral efferent. Those will approach to your orbit and eyeball. Now, we will discuss some important clinical anatomy. One is oculomotor palsy. So, whenever the third nerve will get injured, the most obvious feature is ptosis. Ptosis means drooping of upper eyelid, and it is due to the paralysis of levator palpebrae superioris. Now, complete oculomotor nerve palsy causes complete ptosis, while the division of only the cervical part of sympathetic chain causes partial ptosis because of the involvement of sympathetic supply. Now, when the lid is manually lifted, now the patient is coming to you with the oculomotor palsy, so there is a ptosis. So, you are manually lifting the upper eyelid, and when you will see the eyeball, it is down and out. Now, this is the question for your exam, that what is the position of eyeball? Eyeball is outward rotated and downward. And it is occurs because of unopposed action of the lateral rectus, which is supplied by the 6th nerve, and superior oblique, which is supplied by the 4th nerve. Now, what is the another important thing is that eye cannot be turned upward or inward or further downward because of the paralysis of muscles supplied by 3rd cranial nerve, that is superior, medial and inferior recti. The most important thing apart from these extraocular muscle palsy, in case of oculomotor nerve injury, patient is having loss of parasympathetic responses. That means the pupil is remain dilated. There is a loss of the supply of constrictor or sphincter pupillae, so the meiosis or constriction of pupil is not possible. So the patient does not react to the light, or there is no accommodation reflex. Clear? The consensual light reflex is normal. Now, why it is normal? So you have to understand that we are talking about unilateral oculomotor nerve injury. And I told you that the Edinger-Westphal nucleus of both the side is going to stimulate, so the light pathway is normal. So the opposite side oculomotor nerve is normal, so the consensual reflex is preserved. Ptosis with a large pupil is suggestive of oculomotor nerve lesion. Why? Because constrictor pupillae is not working. But the ptosis with the small pupil is a feature of Horner syndrome. Why? Because in Horner syndrome, sympathetic supply has been disturbed, so the dilator pupil is not working. So this is the important line to understand. If there is a large pupil, that means the constriction is not possible. If there is a small pupil, that means the dilatation is not possible. Now here in this image, you can see that once you will lift this upper eyelid manually, you can see that this eyeball is on the outward side and it is abducted and downward. So abducted and downward eyeball is a classical feature of oculomotor nerve injury, along with the dilated pupil and drooping of your upper eyelid. Now, this is again the very important next question, that fractures of the side of the skull causing dilatation of pupil on the injured side. Why? What is the meaning of the question? That suppose the fracture of the skull of my left side will occur. Now, if the fracture of the left side of the skull occur, my left eye is having problem. Now, what is the problem in the left eye? That the dilatation of the pupil on the injured side. That means again the constriction is not possible. That means there is some involvement of oculomotor nerve which is responsible for parasympathetic supply of your sphincter pupillae. Or the another way of question is that oculomotor nerve is vulnerable for the head injuries, particularly in extradural hemorrhage. Why? So you have to keep this thing in mind, that whenever the fracture of the side of the skull occur, you know that there is an injury of the middle meningeal artery, and that will lead to the hemorrhage, that is extradural hemorrhage. Whenever you have this question, you have to keep in mind that we are always talking about extradural hemorrhage, never intradural hemorrhage. So in this, what will happen? The fracture occurs on the skull, that will lead to the extradural hemorrhage due to the rupture of middle meningeal artery. Now this extradural hemorrhage causes the compression syndrome, like vomiting, like high intracranial tension. But apart from these syndromic features, what will happen? That there is a formation of the hematoma between the bone, skull and the dura. So what will happen? The swelling may cause the pressure on the cerebral hemisphere. Now this pressure, ongoing pressure on the cerebral hemisphere, finally produces the displacement of the medial margin of temporal lobe. What is happening? There is a displacement of medial margin. So this is the medial margin of temporal lobe. Now this medial margin of temporal lobe is having the anterior end here, and this is known as uncus, which is a part of your hippocampal gyrus. So this anterior end of the hippocampal gyrus, which is known as uncus, will displaced medially, and because you have the obturator nerve here on the interpeduncular fossa, this displacement is going to make compression on this oculomotor nerve. So what will happen? There is a herniation of the uncus sucker and it compresses the oculomotor nerve and it hampers the parasympathetic fibers, and the parasympathetic fibers are not able to stimulate the constrictor pupillae, and that is why the eye remain dilated. Clear? Now, then in the oculomotor nerve trunk, the pupillary parasympathetic fibers lies on the surface of the nerve. Now, what does it mean? Now, suppose this is the cut section of your oculomotor nerve, and you know that in the nerve there are multiple small nerve fibers. So, when you will see the arrangement of the nerve fibers, it has been find that in the nerve, the peripheral fibers which are present here are responsible for parasympathetic supply, while the inner fibers are responsible for the somatic supply of extraocular muscle. So, whenever the external pressure will occur on the nerve, these fibers will affect first, which are parasympathetic in nature and present in the periphery of the nerve. So, because of this reason, the pupillary parasympathetic fibers which lies on the surface will get compressed and it will lead to the dilatation or loss of the constriction of pupil. So, thus these fibers may be affected by the pressure, and the pressure can also be caused by the aneurysm or by this type of herniation of your brain tissue. The compression characteristically causes dilatation of the pupil, and there is a loss of the visual light reflexes because of the involvement of parasympathetic fibers. Now, there is one more question, that oculomotor nerve can be damaged by compression of aneurysm in the junction between posterior cerebral artery and posterior communicating artery. I just told you that posterior cerebral and posterior communicating, these all are present here in the interpeduncular area, and here you are having the close relation of your oculomotor nerve. And whenever the aneurysm will occur, they will compress the outer surface, and outer surface of the nerve is having parasympathetic fibers. Now, here you can appreciate again this relation. This is your oculomotor nerve, and here you can see the arteries. So, these arteries, if will get dilated or aneurysm or get ruptured, ultimately the oculomotor nerve fibers of periphery, that is the parasympathetic, will get damaged. Now, there is one more applied, is known as incomplete lesion of oculomotor nerve. Now, incomplete lesion of oculomotor nerve are common, and there may be spare of extraocular muscle or intraocular muscle. What does it mean? That there are two set of the muscle, extraocular and intraocular. Intraocular means in sphincter pupillae and ciliary muscle. Now, what will happen? Suppose the extraocular muscle will get paralyzed, but intraocular muscle remain, or the vice versa, intraocular muscles will get paralyzed, but the function of extraocular will remain. These both conditions are known as incomplete lesions of oculomotor nerve. So, the condition in which the innervation of extraocular muscle is paired with the selective loss of autonomic innervation of the sphincter pupillae and ciliary muscle. So, here now you can see that the patient is not able to respond for the light. Why? Because the sphincter pupillae is not working, as well as the accommodation reflex is lost, but the movement of eyeball are normal. This is known as internal ophthalmoplasia. And what is the most common cause? I told you that the parasympathetic fibers present on the periphery of the nerve, and the most common cause are aneurysm of the artery which are present in the proximity. So, these fibers which are present in the periphery will get compressed, and those will lead to the internal ophthalmoplasia. So, the possible explanation for the involvement of autonomic nerves and the sparing of remaining fiber is that the parasympathetic autonomic fibers are superficially placed within the oculomotor nerve, and they likely to be affected by this aneurysm compression. Clear? And the important thing is that whenever the aneurysm will occur, patient is always having the pain in eye. The aneurysm always causes pain. Clear? What is external ophthalmoplasia? It is a condition where the internal reverts to the internal ophthalmoplasia. That means the extraocular muscles are not working. That means when you will have the nerve, the lesion starts from the center. So what will happen? The somatic supply is going to affect, but the parasympathetic fibers which are on the periphery are normal. So this portion is normal and this part is not working. So what will happen? The light reflex and accommodation reflex are there, but the movement of eyeball are lost. So the condition in which the oculomotor supply, the extraocular muscle is lost, and the innervation to the sphincter pupillae and ciliaris muscle is spared. Now this condition is seen in the diabetes, and diabetic neuropathies are the condition which generally involve the center portion, but the important thing is that diabetic neuropathies are generally painless. So you have to understand this thing, that external ophthalmoplasias are generally painless while internal ophthalmoplasias are painful conditions. So at the end of this class of oculomotor nerve, we are able to understand what is the oculomotor nerve, what are the nuclei, what is the function, and what will happen if different fibers of the oculomotor nerve will get paralyzed. So this is all for today's class. Thank you.